Morning to all of you. Today's my topic is anatomy and physiology of the bowel control. First is the anal canal. Embryologically, it is the part of the proctodome which lie between the anal walls of the pectinate line and the anal orifice. However, surgically, functional anal canal is considered which extend from the anorectal ring or the cranial margin of the puborectalis muscle in the contractile state to the orifice. The epithelial lining of the anal canal is divided into two parts, and the division is formed by the pectinal line. The cranial to it is the stratified columnar epithelium, which extended up to the anorectal ring, and at the anorectal ring, the epithelium thickens and exhibit crypts, goblet cells, mucus-secreting glands, which is typical of the rectal mucosa. And the caudal to the pectoral line is the stratified squamous epithelium, which is the smooth, shiny mucosa without any appendages like hair bulb, hair follicles. At the anal verge, this mucosa puckered by the pull of the coattails of the longitudinal muscles, which causes puckering at the anal verge. The pectoral line also demarcates the deep part of the external sphincter or the lowermost limit of the puborectalis ring. This also demarcates the junction of the upper 1/3 and the lower 2/3 of the internal sphincter. Then the sphincter mechanism. It consists of the first internal sphincter, which is formed by the thickened circular layer of the smooth muscles of the bowel in the area of the anorectum. The caudal rim of the sphincter is palpable digitally as the prominent cushion at the mucocutaneous junction of the anal orifice. However, no precise description is given, and mainly this is based on the manometric findings. And the lack of relaxation of the sphincter causes the constipation in the patients. Then is the external sphincter, which is consist of the three parts: subcutaneous, superficial, and the deep part. This is the deep part, superficial, and the subcutaneous part of the external sphincters. This is the striated muscles. Then the pelvic diaphragm, which is present at the outlet of the bony pelvis in the shape of the diamond, bounded in front of by the inferior pubic and the ischial rami, and posterior by the sacrotuberous and the spinous ligament of the coccyx. Anterior half of this diamond, the anterior triangle is ligamentous diaphragm, and the posterior one is the muscular diaphragm. The muscular diaphragm mainly formed by the levator ani muscle, which arises from inside wall of the pelvis and goes downward and converges in the midline to form hammock-like structure. The posteriorly, this diaphragm form a portal for the anal canal, which is funnel shape, and the muscle diaphragm mostly spans out of the most of the pelvic outlet, except for these posterior lateral to small gaps for two iliococcygeus muscles. This is the hiatus for urethra, and this is the funnel shaped portal for anorectal hiatus or anal canal. Then the elevator ani is mainly formed by the three muscles. First is iliococcygeus, which arises from the white line of the obturator fascia and goes lower down and unites the muscle of the opposite side and attached to the coccyx and form the caudal lamina of the posterior half of the pelvic diaphragm. Then second is the pubococcygeus, which arises from the linear attachment to the back of the pubis and anterior part of the white line through the obturator canal. This extends posterior medially and attached to coccyx and the opposite side of muscle, and also forms the caudal lamina of the posterior half of pelvic diaphragm, just cranial to the iliococcygeal muscle, and this is stronger than the iliococcygeus part. They are both iliococcygeus and pubococcygeus functions as elevation, straightens, and steady and suspension of the rectum. Then third part is rectalis muscle, which is the sling-shaped muscle, arises from the first to fourth part of the sacrum and anchored anteriorly to the inferior ramus of the pubic bone at both sides. It opposes the back and the side wall of the rectum against the anterior wall and jams the rectum against the fixed structure of the triangular ligament, which causes anal canal tilt anteriorly, and the rectum is and this causes rectum angulation between anal canal and the ampulla. Then the nerve supply of the anal canal, parasympathetic and sympathetic. First is parasympathetic, which arises from the second to fourth sacral plexus. It arises from the anterior division of mainly third and fourth sacral plexus, and also the small tweezers from the second one to form the two nervus erigentus, which give short branches directly to the rectum and further to the bladder base and neck of bladder. These nervi erigentis run lateral to the rectum, directly attached to the rectal fascia close to ischial spine, or in the newborn baby at the level of the PC line, which is pubococcygeal line. In the cases of malformation, when the rectum is located higher up in the pelvis, then this PC line PC line, these nerves run more medial course with the perirectal connective tissue beneath the blind ending rectum to reach the region of the bladder basin neck. This is the cause of the difficult in the dissection of the rectum during malformation cases. Then the sympathetic nerve supply, which arises from the lumbar plexus second to fourth, forms hypogastric plexus and further joins at the to the pelvic ganglia, which lies in the parietal layer of pelvic fascia, which can be separated from the rectum during dissection of the malformation cases. The sympathetic fibers are inhibit the bowel peristalsis and motor to the involuntary internal sphincter, which is contraction of the internal sphincter, and parasympathetic nerves are motor to the bowel peristalsis and inhibit the sphincter and relax it, which causes the defecation. This is the hypogastric nerve forms the pelvic ganglia and the nervi erigentus. Then physiology part, the rectal and anal, first is the rectal and anal sensation and control. It is sensation is the carried out by the intrinsic sensory receptor of the anal canal, which is the conventional nerve endings which sense stimulus like pain, tension, pressure, which lie distal and 0.5 to 1.5 centimeter cranial to the walls. This is responsible for acute and fine sensory discrimination, and there is no receptor found at the rectal mucosa. When there increases the content of the rectum, which causes rectal interstension, this causes relaxation of the internal sphincter, and these nerve endings, which is highly sensitive, and the anal canal sensitized, and contraction of external sphincter occur. Then there is extrinsic sensory receptor. However, the main core section of the rectal distension is the main function of parasympathetic nerves through muscle sphincters. The fine rectal distension is responded by the response is arise in the structure surrounding the bowel, mainly receptors present in the puborectalis muscle. Then the continence or the mechanism of defecation. First is the electric property, which occur in two parts: the slow rhythmic potential changes of the membrane, which is known as basal electric rhythm, and the second is the fast spike-like action in between these slow waves, which is known as segmental musculature contraction, which arises by the pacemakers. This is the basic BR with intermittent spike-like waves. These pacemakers synchronize in the oral-laboral direction and also diminish in the same direction, but increases again at the rectosigmoid junction in the direction towards the anus. Thus, the intestinal content can be transported back into the more proximal segment of the content, causes storage in the rectum. The pharmacological part of this is that when there is content in the bowel, the oral part of the bowel constrict by the cholinergic nerves while secreting ACH, and the aboral part of the bowel relaxation by the non-adrenergic, non-cholinergic nerves which secrete nitrous oxide and VIP. In this, the volume of distension is directly proportional to the duration and amplitude of the relaxation. Then the voluntary contraction is occur by the puborectalis, and in this puborectalis and external sphincter act as a unit, and the reflex contraction of the striated anal sphincter muscles during internal sphincter relaxation, which is known as the continence reflex. Then the adaptation reaction. which causes delay in passage of the intestinal content and change in volume per unit pressure, which is compliance of the rectum. The delays passes and this delays the passage and promotes return of the stool into more proximal intestinal segment. But this only occur when there is distal 4 to 5 centimeter of the rectum should be left intact after dissection. If there is only 3 centimeter left, only 80% of the continence will be there. If 2 centimeter, then 50% of the continence will be there. Then there is feeling of fullness during the mechanism of the defecation, which is receptor which is perceived by the anal receptors, tension receptors, and extrinsic receptors in the puborectalis transmit a feeling of fullness and desire to the passage of the stool. This is by the anal distension, which causes the relaxation of internal sphincter and simultaneously contraction of external sphincter in the puborectalis. Then there are corpus cavernous recti, which are the network of the arterial vessels situated at the area of anorectal line. These works as the second plugging mechanism of the anal canal together with the corrugator muscle of the anus and pubococcygis. The venous flow of these vessels drain transsphincterically to the portal vein and fill during the internal contraction, thereby obstructing the upper part of the canal. For this, then the mechanism of defecation is summarized. When the colonic activity propels luminal content aborally, there is filling of the rectal filling occurs, which induce anorectal inhibition reflex, which cause the relaxation of internal anal sphincter and allow anal sampling and discriminate the nature of the rectal content, either it is solid, liquid, or gaseous. And if the defecation is convenient according to the social situation, then the suitable posture and increase of the abdominal pressure, there is relaxation of pelvic floor and anal sphincter muscles, and increase of abdominal pressure by voluntary straining. The rectal pressure increase, and when it increases from the 25 to 30 mg of mercury, the expulsion and the defecation occurs. However, if the rectal filling also generate the urge to defecate by the highly sensitive anal canal receptors, and if the defecation is not convenient, the contraction of the pelvic floor and the external sphincter occurs also. Also the corpus cavernous recti also helps in this, and this was the defecation process. Here,
Good morning, everyone. We'll be taking over and discussing the anatomical principles of surgery in inguinal malformations. The agenda for today is that we will discuss in brief the prerequisites for a normal bowel control in any patient, a preoperative consideration, and the anatomical principles of surgery in cases of inguinal malformation. Brief introduction is that anatomical variations in any case of ARM is a whole spectrum. They can be a very benign perineal fistula to a rectal bladder neck fistula to a common cloaca. This spectrum results in a very different approach to the different varieties of inguinal malformation. Again, discussing in brief the various prerequisites for bowel control. Sensation is detected mostly by the inner canal, which is the most sensitive portion, which is able to distinguish successfully between solid, liquid, and gas. Once the rectum is distended with content, the voluntary sphincter controls the anus. So during surgery, there is attempt to preserve the inner canal if it is present in the patients. Mostly these patients with inguinal malformation, unfortunately, may not have an anal canal except for very rare cases. The next is sphincter. The voluntary sphincter canal is usually tonically contracted, and this prevents the accidental passage of content in these patients. The third and most important is the rectosigmoid mobility as well as the reservoir function. The rectosigmoid is normally relaxed, and this detects content by the proprioception. It acts as a reservoir for fecal matter. So if the rectosigmoid is removed, that results in the loss of the reservoir capacity, hence leads to increase in frequency of bowel movements. However, if the anus is preserved after we were removing the reservoir, the availability of sensation from the anus causes a voluntary a conscious effort to avoid the bowel movement each time. So if the anus is damaged, if we can preserve the reservoir, at least that helps in aiding in some amount of continence. So if we are having without a patient without a reservoir, that can ensure in permanent fecal incontinence. Next, in brief, how the nervous supply in patients. Basically, the nervous supply innervating the urogenital tract arise from the sacrum and they run lateral to the rectum. As Dr. Douglas Stevens has been recommended that in surgery, the principle is to always stay in the midline and close to the rectal wall during dissection so that we can avoid damage to these nerves. Next is the blood supply. The blood supply of the rectum is said that rectum has a very excellent intramural blood supply. Even despite a very extensive dissection of the rectum, it is still seen to remain viable. That is because of the good supply from the inferior mesenteric artery and its branches. The inferior mesenteric artery contributes to the superior hemorrhoidal artery, whereas the internal iliac contributes to the middle and the inferior hemorrhoidal artery. As previously mentioned, the inferior mesenteric artery is forming the superior hemorrhoidal artery. Then from the iliac, we have the middle and the inferior hemorrhoidal artery. And this is the blood supply of the rectum. However, we have to remember that during the first procedure, that is a colostomy, we might end up interrupting the colonic arcade. So the rectosigmoid only has blood supply from the inferior mesenteric artery. So we have to be very careful not to ligate the whole of the mesenteric artery. A few peripheral branches may be ligated, and the presence of the proximal branches of the inferior mesenteric artery will thus help in perfusing the whole of the rectum and preserving the vascular supply of the rectum. Then coming to the decision making in these patients, as we know, we have to always screen for associated anomalies. If we are seeing a perineal opening, we do not need any further colorectal imaging. But if we are not seeing any fistula, preoperative imaging is quite essential in these patients. If we know the location of the fistula and the location of the rectum, as well as the presence of associated anomalies, we can potentially prevent surgical misadventures, and this can thus guide us for proper surgical planning. For example, there are some telltale signs that we must look for in patients when they present to us, such as a patient presenting with a very flat bottom in the neonatal age with absent perineal groove, an absent anal dimple, or a bifid scrotum. These are all telltale signs of a very high ARM that would suggest that the child might require a colostomy. Then there are some telltale signs of perineal fistula. Perineal fistula may not always be obvious as an opening in the perineum. We might miss that out. So there are other features that may suggest that child has a perineal fistula. They may be associated subepithelial tract of meconium in the perineum, or there may be a bucket handle malformation. And on expressing that, then we'll see a drop of meconium. Then we'll be realizing the fact that it is in fact a perineal fistula. What if we are not able to find a fistula? Then what do we do next? Then we have to go for a cross-table lateral film that is usually done after 24 hours. That is to see the position of the rectal gas. We place the patient with a bump under the hips, and that is to apply pressure on the abdomen. And this is to also ensure that the air is forced distally into the rectum at this time. But unless the gas is able to actually cross the levators or the pelvic floor, this may not be accurate in determining the potential distance of the fistula or the rectum to the perineum. Coming to the principles of a stoma in these patients, we do not go for a transverse colostomy in these patients because, as we know, there is a high likelihood of prolapse of the transverse colostomy that causes a very difficult distal cologram in these patients. There can be urinary absorption via the fistula that can lead to hyperchloremic metabolic acidosis, and there can be distal fecal impaction that can lead to a megarectosigmoid that will affect our future surgery. But in very few cases of anatomical malformation, it has been traditionally thought that a transverse colostomy can allow for all options of surgical reconstruction in the future if we require bowel dystally, and the blood supply would not need to be divided, and the distal colon could be used for, say, a vaginal replacement if required in the future. Although the preferred stoma in an ARM is the divided or a loop sigmoid colostomy, that is at the first mobile portion of the sigmoid. This is to avoid the prolapse, and we constructed with a tiny mucus fistula which aids in doing our distal cologram, and also to and at the time of creating the stoma, we have to also ensure an intraoperative wash of the colon. These are all acceptable forms of a high sigmoid divided colostomy with a tiny mucus fistula. If we are doing a loop colostomy and it is improperly done, there can be stool impaction in the distal limb, and the distal limb may prolapse if we are not tapering it the right way. If we are opening it too distally, that may interfere with our future pull-through procedure as well. Then the main discussion for this seminar would be operative decision for approach to a rectum in patient. How do we decide if we have to go for a PSA procedure or a LAR procedure? The most widely accepted way to determine the location of fistula in the patients is the distal cologram. Whenever we perform a distal cologram, there should be some points that we have to ensure are done if we're to make it a technically correct cologram. We have to insert the catheter in the mucosal fistula side, and we should be able to see the dye going from the mucosal fistula side. We should be able to appreciate well the amount of the bowel length available for the pull through. That is one purpose of our cologram. We should be able to see if we are suspecting a fistula, we should be able to demonstrate the fistula and the rectal end in communication with the urinary tract. The tip of the sacrum, this is very important that the lateral film should be taken where, sort of oblique film in which we want to see the tip of the sacrum or the coccyx, the urethra and the bladder, and the anal marker should also be placed in patients. So very briefly, the procedure that we do is we insert a balloon catheter in the distal colon at the mucus fistula. We have to make sure that it is in the distal loop. There have been instances where it has been inserted in the wrong loop, and that can destroy a study. We inflate the balloon and we inject the contrast medium, and we have to ensure that we're giving very adequate pressure to allow the contrast to flow distal to the levator complex. This cologram will then outline the distal aspect of the rectum and up to the rectourethral fistula if it is present. We need a true lateral view to determine the location of the fistula as well as the rectum, which is relative to the tip of the coccyx, is also what we are looking for. The AP view is, however, needed to show the length and the redundancy of the rectum in these patients. Usually it is seen that the fistula starts getting apparent once the child passes urine during this procedure. If we are seeing that the bladder is filling very quickly, then it is most likely a high rectoprostatic or a rectobladder neck fistula. But if the bladder is not filling very quickly, but the urethra is filling easily and the child is voiding very quick as soon as we're doing the procedure, the fistula will most likely be below the urinary sphincter, either a low rectoprostatic or a rectobulbar fistula. There are some recent advances that may compare with the cologram, including a contrast enhanced sonography, MRI, or even injection, or they even suggest not going for contrast, rather going for water that is injected high pressure, and we're looking at it under an ultrasound or a magnetic resonance imaging. Then after we have a cologram, we would decide for if we go for a PSA or a LAR. We will look for the horizontal line from the pubis to the tip of the coccyx, that is the PC line, or the the ossified portion of the sacrum that we visualize. If the first structure that we are seeing from below is the rectum, then we would decide that a PSAB would be preferred in this patient, because if we start the surgical dissection, the rectum would be in front of us. But if the first structure that we are going to encounter is a urogenital anatomy, we will always go for a LAR in this patient, because we will not be able to encounter the rectum from our perineal dissection. The significance of the PC line is that the pelvic muscles are compressing the rectum at this particular level. The decision, again, as mentioned, it is based on a well-performed distal cologram. We look at the pubococcygeal line, and depending on if the first structure encountered from below is the rectum or the urogenital structures, we go for a PSA versus a LAR. In this, we can see the first image showing the rectum is well below the PC line, so we may consider going for a perineal approach. In this, we may see that it is actually opening up high up into the say the bladder neck, so it should be approached from laparoscopy rather than a perineal approach. So if you have to search for the rectum above the coccyx, it's going to be much easier with the laparoscopic approach. What happens if we are inadvertently going for a patient in which the rectum is actually below the peritoneal reflection? This leads to very unnecessary intra-abdominal mobilization of the bowel. This can lead to further prolapse and ischemia. there can also be a remnant of the original fistula, because we might not actually end up reaching the fistula and we might inadvertently end up leaving behind a remnant. This portion can remain as a diverticulum. They can be resulting significant UTI in these patients. They can develop multiple episodes of mucus formation in the urine. They can develop stone, or even cancer can be seen in the remaining diverticulum that is left behind. If the patient is not having a fistula, we may notice that it's a distal, if it is a well-performed cologram and we are not encountering a fistula, if we want to decide surgery in these patients, again, we look for the position of the tip of the rectum with the PC line accordingly. And we can actually see that most of the patients with Down syndrome and the present, they will have without a fistula. So that can also aid in our diagnosis. If a cologram is done without adequate pressure, this may ensure us missing a fistula in these patients. Then in brief, the spectrum of defects for which we are going to do the anorectal surgery. The perineal fistula, the sphincter mechanism is almost normal in these patients, and the deviation of the rectum is just at the lowest portion, and it opens within the perineal body just anterior to the sphincter complex. These patients can have 100% chance of bowel control in a well-performed procedure, and ensuring that the child does not have any associated anomalies, because these children are surprisingly found to have presacral masses or tethered cord even, although it is a low defect. In the rare chance that we encounter a very long perineal canal, the posterior sagittal approach is definitely required to reach up to the perineum. If the perineal opening that we notice is in the scrotum, we are going to encounter some difficulty, because we know that there will be a chance of a long fistula that is running along the urethra, and we have to be very careful, because we may risk injury during this repair. The next is rectobulbar, in which there is a reasonably good sphincter mechanism. It connects to the lowest portion of the urethra, that is the bulbar urethra, and there is approximately 85% chance of bowel control in these patients. Rectoprostatic, there is a slightly weaker sphincter mechanism. In these patients, one issue is that as the rectum is opening up higher up, the distance available between the sacrum and the pubis will be short. So the space for the pull through and the space for us to actually approximate the perineal muscles will be less. And these patients are seen to have around 60% of chance of bowel control. So as we go higher up, less space between the pubis and the sacrum, there is also higher chance of encountering other associated anomalies like tethered cord. The last is the rectobladder neck fistula, where the sphincter mechanism is quite poor. The rectum may not fit due to less space, and these patients only have 20% chance of bowel control. Coming to the intraoperative preparation of these children, a Foley's catheter is to be inserted, and we may require cystoscopy for even continuation of the fistula before a surgery. And some children may have difficult catheterization, and the catheter might keep going into the fistula. So we might need to require cystoscopy for aiding in our catheterization as well. It is said that silicone catheters are preferred over latex. There are some concerns about allergy. And again, as mentioned, the blind catheterization may fail in male patients due to the catheter passing again and again into the fistula. So a cord-tip catheter or a cystoscopic catheterization are alternate options. Urethral injury in males is not uncommon, so we have to ensure that the catheter is there. And the catheter is kept for a longer period in boys, and it is also seen that a higher malformation, we prefer a longer duration of catheterization. Also, the catheter can help prevent the anaplasty from soiling. If the urethral catheter is anytime dislodged in the postoperative period, we should not repass it, because it can lead to disruption of the wound, because we would have done a urethral repair in these patients. Coming to how to locate the sphincter complex, we require a proper muscle stimulator for locating the sphincter complex. This is usually preferably done before the muscle relaxant is given by the anesthetist. The stimulation is done along the midline, and the sphincter complex can be identified as a 2 to 3 centimeter long hyperpigmented area. There may be a dimple in the perineum or a pigmented region. That is the sphincter complex. The contractions of the sphincter complex should be they are perpendicular to the skin. That is the location that the surgeon is marking. The parasagittal fibers that are superficial their contraction is parallel to the skin. And also, the higher the fistula in these patients, the more anterior the chance of encountering the sphincter. In this, we can see that the parasagittal fibers are pulling front to back, whereas the sphincter complex is pulling it up, like pulling it inside. Then we'll discuss a few key steps in the surgeries. The first is PSARP. The patient is in a prone position with the pelvis elevated. We mark the sphincter complex location prior to the surgery, and the incision is a midline incision that is from the inferior portion of the sacrum to the anal dimple, and it is deepened in layers. The layers that we encounter are the parasitical fibers, main like layers encountered the parasitical fibers, ischiorectal fossa, the levator muscles, and the sphincter complex. We have to ensure that we are adequately retracting. We can use a weak liner retractor for the same. And if the adequate retraction is available and we are going in the midline in layers, we will encounter the posterior wall of the rectum that is identified. The key identification is there's a white fascia surrounding it. Once we are dividing the parasitical fibers, the ischiorectal fossa, then we find the levator muscles that are deep to it. And then once we keep dissecting this, we will encounter the white fascia of the rectum. In patients, we have to dissect first lateral to the sphincter that we're encountering. Then we slowly proceed anteriorly because we know there's going to be a common wall between the rectum and the urethra. We have to be very careful not to injure that. So once we have got proper visualization of the rectum, we incise the rectum in the midline and then we start applying sutures on the wall. So once we have applied suture, we keep incising it because we know that the rectum is terminating eventually into a fistula. So we keep applying sutures and we keep incising it in the midline. And as we proceed, we will eventually reach the fistula. The fistula is always found in the midline, that is going to be at the distalmost portion. And once we are reached the fistula, we take a stitch in the midline, that is in the lower edge of the fistula, and we may probe it just to confirm the position of the fistula. So these are the sutures taken at the margins of the rectum that we've incised, and this is the suture that is taken to visualize the fistula and apply traction on it. We start with a submucosal dissection that proceeds to full thickness, and that is to separate the common wall because they do not have any plane of dissection, so we have to keep creating a common wall while we're doing this dissection. It is also said that the lower the malformation, the longer the common wall, so our dissection has to be very delicate when we are doing the same. The common wall between the urethra and the rectum. The incision that is given on the rectum is approximately 1 to 2 millimeter, that is and the superior aspect of the fistula, and this dissection is proceeded initially submucosally. Then we start to dissect the rectal wall of the urethra, and we proceed to completely free the rectum from the urinary tract. We'll close the fistula with suture. The dissection then is taken proximally until the peritoneal reflection, that is to attain ensure the peritoneal reflection. If it is a little higher up in rectovulva, we don't usually need to do that. This is to attain a repair with little or no tension to the rectum once we're pulling it out. And the main goal is to place this rectum that we pulled out into the sphincter complex. Once we have placed it successfully in the sphincter complex, we start the closure. We close the levator muscles. The muscle complexes have to be closed to the midline, and the wound is closed in layers. We also ensure a rectopexy is done to anchor this rectum so that it does not prolapse or retreat back. And the perineal body reconstruction is also done. In patients of rectourethral fistula with an inadvertently long fistula encountered, the long length of the fistula can be left as it is because it risks urethral injury, and there is also a very significant chance of spongiosum bleed if we end up injuring the urethra. In case of PSRP for patients of vestibular fistula, the multiple stage suture, we have the same position. We can also do it in anterior sagittal position as well. The multiple stage sutures are taken around the fistula circumferentially, and we proceed with our dissection. The incision in this is from the lowest part of the coccyx to the orifice of the fistula. And the goal is to carefully separate the rectum from the vagina. Although we are not going to encounter any urethra or any structure, we can end up causing an iatrogenic rectovaginal fistula for, say, if we have an injury on the rectum, that wall is opposing the wall of the vagina, and we've ended up injuring both, they may end up fistulizing with each other and form an iatrogenic rectovaginal fistula. That would require a reoperation in these patients. So that is our goal in this. Because it is not limited to the levator, that we call PSARP in vestibular fistula patients as a limited PSARP. Then coming to PSRP in perineal fistula, that is called a mini PSARP. In this, it is called a mini piercing because our incision is just going to be involving the sphincter mechanism. We will not go up to the sacrum, of the coccyx. The procedure is eventually that we take multiple stage sutures on the fistula circumferentially, and we go circumferentially dissecting until we are able to completely mobilize the rectum, and we proceed for the anoplasty after that. In case of female patients, also it is the same, that we proceed to circumferentially dissect it, and then we relocate the anal opening and a formal anoplasty is done. We separate the rectum from the vagina in these patients. The next is laparoscopic approach. In laparoscopic approach, the patient's position is lithotomy position. Once we have entered, the major goal is to dissect close to the rectal wall and follow it distally until the caliber of the rectum becomes thin. That is where we know that the rectum is going to ensure into a fistula. And once we have hooked the fistula properly, we can divide it. The suture ligation is done of the end of the fistula, and under this laparoscopic guidance, we create an opening in the neo-anus opening is created, and under laparoscopic guidance, we will insert instrument and we'll grab the rectum that we mobilized and pull it out through the perineum. Our goal will be to recreate the rectal angle. The tension should be appropriate during this procedure. We should avoid any postoperative retraction, stricture, or prolapse. The rectal wall is tacked to the posterior edge of the muscle complex. Then we go for the anoplasty that we normally do. In this image, we can see that once the fistula has been circumferentially delineated and mobilized, the fistula has been ligated using an endo loop. And we have to also make sure in laparoscopy that we are able to ensure the rectum has adequate blood supply. Lastly, the closure of the fistula. The closure of the fistula in laparoscopy is done by suture ligation, by application of clips, even or stapler. There are a few who even choose to leave the fistula open in place for at least 2 weeks with a Foley's catheter insert.